What's up, everyone? Today I'm doing a rapid review of glycogen storage disease type 5, also known as McArdle disease. McArdle disease is an autosomal recessive inherited metabolic disorder affecting muscle metabolism. It's caused by a deficiency in the enzyme myophosphorylase, also known as muscle glycogen phosphorylase, which is encoded by the PYGM gene. This enzyme is essential for breaking down glycogen stored in skeletal muscle into glucose 1-phosphate. Because of this defect, patients cannot access their muscle glycogen stores for energy. The condition is characterized by exercise intolerance that typically presents in the first decade of life, though diagnosis is often delayed. The classic presentation involves rapid fatigue, muscle stiffness, and cramps, also known as myalgia, occurring within the first few minutes of exercise. Symptoms are most often triggered by isometric exercise, like heavy lifting, or sustained aerobic exercise. A unique and high-yield feature is the second wind phenomenon. If an affected individual rests briefly after the onset of pain, or continues exercising at a lower intensity, their symptoms often subside and their heart rate drops. This occurs because the body switches metabolic pathways to utilize blood-borne glucose and fatty acids, bypassing the blocked glycogenolysis pathway. If warning signs are ignored and exercise continues despite pain, severe complications can arise, such as rhabdomyolysis, which is the breakdown of muscle tissue, and myoglobinuria, which is the release of myoglobin into the urine, causing it to turn dark red or brown. This carries a significant risk of acute renal failure. Now, diagnosis is historically associated with the forearm exercise test. The classic finding is a failure of blood lactate to rise after exercise, also known as the flat lactate curve, despite a normal rise in ammonia. However, diagnosis is now primarily established by molecular genetic testing for biallelic pathogenic variants in the PYGM gene. Serum creatine kinase is almost invariably elevated, even at rest. Management relies on lifestyle modification rather than medication. So key strategies include dietary intervention, ingestion of simple carbohydrates like sucrose or a sugary drink shortly before exercise can improve tolerance. There's also exercise modification. Regular, moderate intensity aerobic conditioning is encouraged to improve the second wind capacity. However, intense isometric exercise and anaerobic bursts must be strictly avoided to prevent rhabdomyolysis. Lastly, there's surveillance. Routine monitoring of CK levels and kidney function is recommended to detect silent muscle damage. And that's your rapid review. Hit that like and subscribe button for more quick study tips, and I'll see you next time.